code about halfway through. I'll apologize for that. I try to be as open and as forthright with any element of speaking that I do. If you all are not part of the Facebook group, we have a Facebook group. It's called the Institute of Regenerative Education. Many of you have probably seen me in there. I do TED Talk style lectures, and I throw a new lecture up every week. This is going to essentially cement, in God willing, about 2 hours, 50 videos that I put in that Facebook group. And so if you don't catch this lecture in its entirety, if I talk too fast, which I tend to do, if you just need a bit of a drill down, 2 things. Number 1, please join the Facebook group. It's the Institute of Regenerative Education. You'll have to answer a couple questions. Please state that you were referred by Dr. Martin. That's number 1. Number 2, what I tend to say over and over is that the field of regenerative medicine is either sold or it is taught. And the only way you can teach the field of regenerative education and the field of regenerative medicine is with receipts. So at the end of this lecture, everyone who's attended will be getting an asset list. That asset list follows my course through this lecture and has referenced publications, usually peer-reviewed PubMed indexed publications, for everything that I'm going to be speaking about tonight. So if there's any question about what I've had to say, if you have any consternation or it challenges you, please go to the literature because I've referenced it, and we'll walk through together this really art of medicine. Now, the goal tonight is very simple. The goal is to separate the myth of regenerative medicine from the practicality of medicine. Most of you have probably seen the movie Harry Potter. And for probably the last 10 years, regenerative medicine has been no different than having a little magic wand. You know, you had doctors out there, you know, casting a spell, you know, Wingardium Leviosa. And they just promised that they would elevate your overall health. We're going to give you stem cells to treat ALS. We're going to treat osteoarthritis. We're going to treat your long COVID. And in the course of all of that discourse, you had companies make very aggressive claims. You had companies get cited by the FDA for those claims. And you had other companies that kind of stood apart. And they decided to do something different. And instead of market, they decided to educate. I'm going to start with a story. When I was a resident and had just finished residency, I started to do spinal cord stimulation. And in the process of doing spinal cord stimulation, I wanted to be able to not only put my own leads in, but I wanted to be independent. I wanted to be able to put the battery in, which required me to actually make a surgical pocket. Now, my father's a head and neck cancer surgeon. I'm not a surgeon. I'm a needle jockey at best. I'm an interventional pain doctor and have been for 25 years. Well, I was fortunate enough to attend a training, a hands-on training, and a very prolific plastic surgeon was there. And he was teaching everyone about how to make a surgical closure. And so he walked into the cadaver lab, and he wasn't wearing a bunny suit and he wasn't wearing scrubs. He was wearing a $3,000 suit, and his tie was a $1,500 tie. Now, the reason I know it was a $1,500 tie is because he told me so. And he was wearing an Hermes tie at the time, and so I figured I'd break out the Hermes for this evening, because he said something that stuck with me. He said, as a plastic surgeon, you have 2 jobs. Your first job is to make what you do look good. So never overpromise and underdeliver. And he said the second job is to look good while you're doing it, as he stroked his $1,500 tie. Now, in the field of regenerative medicine, we have had it backwards for a long time. and we have made crazy claims. Let's just dispel some myths, first and foremost, all right? When we're talking about the field of biologics, all right, everyone's heard of the term stem cell, all right? Almost everyone understands that this term, to the layperson, does not mean differentiated mesenchymal stem cell. It doesn't. What does that term mean to the layperson? It means magic. It means Harry Potter wand. It means if I write a check for $10,000, I'm going to suddenly get better. And because I've gotten stem cells, that they're magically going to go to exactly the place in the body that's damaged or deranged or has some inflammation, and they're going to heal that malady. This is a farcical claim. It's irresponsible, and it's the very reason many biologics companies have warning letters from the FDA. Because stem cell as a term is about as specific as fibromyalgia. Almost all of you watching this have seen the evolution of fibromyalgia. We used fibromyalgia 10 years ago because we thought patients had fibro. You could do genetic testing for it, right? What did fibro become at the height of the narcotic epidemic? Well, at the height of the narcotic epidemic, it just became a diagnosis that you could give a patient so you could write them a script. What is fibromyalgia now? Now it's not a rule out. It's almost a rule in. If you have fibromyalgia, just like saying that I'm going to give you stem cells, in most savvy doctors' offices who have a high index of suspicion, when they hear fibromyalgia, what they hear is that's a trash diagnosis. There's probably something else more egregious going on, and my job is to dig in deeper. And so I understand the temptation to use the term stem cell because people are familiar with it. I think that's irresponsible. I think in this day and age, we need to get granular when we're talking about biologics to patients. Specifically, if you are going to use the term stem cell, please differentiate. Are you talking about pluripotent? Or are you talking about differentiated mesenchymal stem cells? Because the two are very different. All right, what separates the two? First and foremost, pluripotent stem cells are typically derived from fetal tissue, and that is usually aborted fetuses. Now, of course, there are some religious consternations around that, but because pluripotent stem cells are derived from fetal tissue, they can turn into anything in the body, any cell lineage. They are a progenitor cell. They can turn into anything in the body. And for that reason, they can also turn into cancer. Now, I'm 52 years old. And at 52, I'm certainly closer to the finish line than I am to the beginning. And so, do I have more genes in my body? Do I have more cells in my body that are susceptible to becoming oncogenes or susceptible to mutation? Sure, I do. And so, if I got millions of pluripotent stem cells by IV, it's just as likely that I could turn on an oncogene. I could feed a microcalcification, as it would be that, I would down-regulate inflammation. Most of us are familiar with a cloning project that happened in the mid-2000s, 2010, 2012, where we cloned a sheep. That sheep's name, and I've said it errantly in the past, but that sheep's name was Dolly. Okay? Most people have heard about Dolly. They know about Dolly. What most of them don't know is that Dolly was created using pluripotent stem cells, and that Dolly died at 4.5 years of life of metastatic cancer. Most people don't know that Dolly had 5 baby sheep, and all 5 baby sheep died of metastatic cancer within 2 years of life. This is why pluripotent stem cells are illegal in the United States, and they have been since George W. Bush was president. Now, are there some companies selling pluripotent stem cells in the US? Sure there are. Would I encourage you to get pluripotent stem cells, either here in the US or internationally? I say buyer beware, all right? Me at 52, I don't have a strong family history of cancer, but I don't really feel like that coin toss is going to come up heads. It's probably going to come up tails. And, I'm going to get to pin the tail on the cancer donkey, and that donkey is going to be me, and I'm not excited about that. How are differentiated mesenchymal stem cells different? Well, let's get into that. First and foremost, differentiated mesenchymal stem cells are not progenitor cells. They are differentiated. They are further down the phylogenetic line. And because they are differentiated, they cannot become just anything in the human body. So let's get into it just a bit, all right? So if we're talking about strictly differentiated mesenchymal stem cells, we have two sources in the human body for those differentiated mesenchymal stem cells. We have autologous and we have allogenic. Now, autologous are in-body stem cells, meaning that they come from our own blood, fat, and bone. All right. You may be familiar with these as PRP, SVF, and bone marrow aspirate concentrate.
The whiteboard looks good, by the way, Dr. Marr. I know you're stressing about that. I just want to let you know it's very clear.
The allogenic differentiated mesenchymal stem cells are out of body. What's the source? The source is typically umbilical cord tissue. Now, we're going to do a pretty deep dive into this, but I just want people to understand, all right? All of these differentiated mesenchymal stem cells fall under a regulatory category of 361 by the FDA. Okay, I get asked all the time, are mesenchymal stem cells legal in the United States? Let's just dispel the myths, all right? All differentiated mesenchymal stem cells fall under Section 361, all of them. That means autologous and allogenic. I don't care what the PRP rep says, all right? These all fall under Section 361. Now, let's get a bit more granular because I'm a granular guy. What is PRP, SVF, and BMAC? What are these? These are 510K cleared kits. That is all they are. So when your PRP rep says, hey, our PRP kit's FDA approved, the kit is approved as a 510K medical device from China. Once you make that kit and mix it with blood, it now becomes a human cell and tissue product regulated under Section 361 by the FDA. So when your PRP rep says to you, hey, look, our kits are FDA approved to treat osteoarthritis, they are not. Because no PRP, stromal fat, or BMAC, or allogenic biologic can be used to diagnose, treat, prevent disease. I'm leaving this disclaimer at the bottom for the entire lecture. And I'm going to come back to this over and over and over again because it plays hell in people's practices. No, no human cell and tissue product can be used to diagnose, treat, cure, prevent disease. I didn't even put cure in here because it's so obnoxious to use that term when we're using a differentiated tissue-based biologic that I won't even justify by putting it on here, but I'll put it in parentheses. I'll put it here, cure. And I'm going to make it very small because it's just completely obnoxious to use that term if we're talking about differentiated mesenchymal stem cells. Okay. Sorry, I live and die by coffee. Allogenic biologics. Your allogenic biologics are typically from umbilical cord sourced tissue. Where does that umbilical cord sourced tissue come from? In the United States, it should come from an AATB certified lab. What does that mean? That means that a lab that's using typically ISO 7 certified processes from the FDA has taken birth tissue from full-term consenting women, meaning a woman's going to have a baby. She gets a little questionnaire. That little questionnaire says, do you consent to donating your afterbirth, your umbilical cord and your placenta, to science? Science? Well, science is us. We are the scientific community that benefits from every mother donating her placenta and her umbilical cord. Okay? That AATB certified lab, and there are plenty across the country, have extremely specific guidelines for how they harvest tissue. Right? Almost all tissue should be vaginal delivery. We'll explain that in a second. All of that tissue is typically screened for COVID vaccination, cytomegalovirus, herpes simplex virus. And to be perfectly honest, I would hate to run a tissue bank because that umbilical cord that goes to that AATB certified lab has to be adjudicated through that patient's entire life. Every vaccine, every disease, every prescription drug, any viral illnesses that patient has ever had, all of that has to be evaluated. And only once that's been evaluated and it's been determined that that cord is clean, can it then be donated for processing and eventually end up in a little cryopreserved vial that might get shipped to you overnight on dry ice. All of that has to happen before you get this cute little product in a little plastic vial on dry ice. So are differentiated mesenchymal stem cells legal to use in the United States? Yes. A doctor can practice medicine. These are all FDA cleared, meaning that the process by which umbilical cord tissue is processed is cleared by FDA approved facilities. That the kits are 510K cleared kits. However, the application in the course of treating a patient is approved for experimental cosmetic research basis, okay? It cannot be used to treat, prevent, or diagnose disease. So, to review, if somebody wants to use PRP to treat osteoarthritis, can they do that? No. Why? Let's get into it. Because it really isn't that difficult. I tend to be a fairly common sense guy, and I like to make things common sense. And I'm going to leave the FDA up at the top because they are the ever purveyor of what we do. All right. Meaning that all human cell and tissue products in the application of them is governed by the FDA. I just happen to be one of a few doctors in the country that testifies under oath at the federal level of appeals, defending doctors like you all when you make claims or when you run afoul of the FDA. We're going to take two scenarios, all right? Scenario one is a 24-year-old patient. Scenario two is a 74-year-old patient. And we are going to apply the simplest paradigm for using any human cell and tissue product that I think maybe anyone's come up with, all right? And it is literally this. You have three overlapping circles. And it is here that you make your decision, right here. Okay? Those three overlapping circles are the patient's health, the category of cartilage-based derangement, and the type of cartilage-based derangement. Doesn't mean anything to you right now, all right? But we're going to walk through two scenarios, all right? Our 24-year-old patient has a grade 1 meniscal tear. That 24-year-old patient is very healthy, okay? Because that patient is healthy, an injury to his knee, say playing pickleball, right? We have to make a decision based on how we're going to use a human cell and tissue product, Section 361 product, whether autologous or allogeneic. Well, at 24, he's on no medications, he has no systemic disease, right? And after he had the injury, he had a minor bit of swelling and then the swelling subsided. What do we know just in that history? This patient's healthy. He's got a robust immune system. He had some inflammation. His body was able to downregulate that inflammation post-injury. Okay? He has a meniscal tear, meaning he has a soft tissue tear. This is incredibly important. Why? Here is our femur. Here's our tibia. Here's our fibula. All right? The articular cartilage over the femoral condyle and the tibial plateau is what? It's type 2 cartilage. The internal structures, meniscus, ACL, PCL, medial collateral, lateral collateral, those are type 1 and type 3. Our 24-year-old's young. All he had was a soft tissue injury. And so being healthy, all right, the type of cartilage-based defect is what? It's type 1 collagen and type 3 collagen because his meniscus is type 1 and type 3 collagen. All right. Now, what's the category of cartilage-based derangement? There are 4 categories: orthobiologic, cosmetic, neurologic, and immunologic. What is the category of collagen-based defect? It's orthobiologic, okay? So if we're thinking about an orthobiologic, it's going to have at least type 1 and type 3 collagen subtypes. In a healthy patient, what are our options? Well, we've got 2, right? Well, actually, we have more than that, all right? In a healthy 24-year-old, would we even consider bone marrow aspirate concentrate? I think that is egregious. I think putting a trocar and hammering it into the hip for a 24-year-old is egregious, and I think that makes no sense, all right? There are other reasons it makes no sense as well, all right, and we'll dive into those, all right? But if we're looking at all of our potential allografts, our 361 differentiated mesenchymal stem cell-based products, we have PRP, we have BMAC, we have SVF, and really we have umbilical cord tissue or Wharton's jelly. All right. BMAC, I think, is too aggressive. That's out. SVF. Would there be a reason to use stromovascular fat? I don't think so. He's 24. Is he going to have a whole lot of fat on him? I don't know, but is it worth it to do a liposuction on a 24-year-old? I think that's too aggressive as well. All right. So what does that leave us with if we're going to use an orthobiologic? Because that's the category of cartilage-based defect. And we want at least type 1 and type 3 collagen. What collagen subtype do we have in PRP? The only collagen subtype in PRP is type 1 collagen, fibrin. What about umbilical cord tissue? What collagen subtypes are in umbilical cord tissue? There's type 1 collagen, there's a little type 2, there's type 3, there's also type 5, 7, and 9. I know that's small because there are small amounts of that. Now, if we're really being specific, there's also hyaluronic acid in there as well. All right. Now, if this 24-year-old is just a casual pickleball player, PRP might be enough. And the reason PRP might be enough is because PRP works by way of a pro-inflammatory process. We're going to explain that next. That pro-inflammatory process means that when I take blood out of the arm and I spin it down and I put it in a centrifuge and I inject it in the knee, I'm going to get an inflammatory response. That inflammatory response is going to stimulate M1 macrophages. Those M1 macrophages are going to stimulate excitatory cytokines and interleukins, specifically TNF-alpha, IL-1 beta, and IL-6. Those are going to cause inflammation. Because this patient's healthy, he doesn't have an impaired immune system, he doesn't have an impaired humoral response, he can down-regulate that inflammation. He has that feedback inhibition loop intact. Because he can down-regulate that inflammation, this is an option, all right? What's the other option? The other option would be Wharton's jelly, because that soft tissue injury to the meniscus is a type 1 and type 3 cartilage defect, and certainly Wharton's jelly histologically has robust amounts of type 1 and type 3 collagen. Either is a decent choice, all right? How do you determine which to use? In my view, what's the level of pickleball he's playing? If he's playing recreationally, failed rest ice elevation, failed cortisone injections, doesn't want to have surgery, all right? I think PRP is reasonable. If he's competitive and he's playing 4 or 5 times a week and he wants to actually try to go pro, I don't think there's any choice in the world. I think you use Wharton's jelly without question. You're going to get more robust collagenous differentiation, something we'll talk about next. All right? Now, let's run this whole scenario for a 74-year-old. That 74-year-old, all right, has the same meniscal tear. Doesn't have a grade 1, say he's got a grade 2, right? He's got a grade 2 meniscal tear, all right? But he also has long COVID. He also has, let's say, lupus, all right? Just that changes this whole paradigm substantially, all right? Is he healthy or unhealthy? He is unhealthy without question, all right? What's the degree of cartilage-based defect? Well, he's got a grade 2 tear. What do we know about a grade 2 tear in a 74-year-old that also plays pickleball? Well, his defect is not going to be just type 1 and type 3. He's going to have some degeneration of the articular cartilage as well, which is type 2 collagen. Now, we reviewed earlier the possible applications, right? The possible applications when other things have been exhausted. And this is important to note. All right. This 74-year-old, just like this 24-year-old, they didn't walk in off the street. They exhausted conservative measures, and either steroids were ineffective or they couldn't have them for some reason. Maybe the patient has brittle diabetes. Maybe this was a type 1 diabetic. Obviously, cortisone injections are not a great idea. All right. This patient's already frail. They've got lupus and they have long COVID. All right. So steroids probably aren't a great idea because they're probably on steroids already for their lupus, or at least have been. So are they going to have a robust response to corticosteroids in the knee? No. What are repeat corticosteroids in the knee of a patient with lupus going to do? Probably make that patient a lot worse, because that lupus patient depends on steroids when they have a flare. So if you're thinking, oh, I'm going to help them out by giving them steroids because they have a grade 2 meniscal tear, all you really did was pretty much ensure that the next time they have a lupus flare, that the steroids don't work as well, and their flare ends up being worse, and they get more sick because you blunted their response to IV steroids by giving them injectable steroids to collect $59.50 from Medicare. And we'll go over that as well. All right. So in this scenario, are steroids a good idea? No. Right. So now we're in the realm of orthobiologics. Is this a healthy patient? We've already determined that it's not. So is surgery without risk in a patient with long COVID and lupus? Absolutely not. There's certainly risk putting that patient to sleep and doing arthroscopy with this knee. So is that an appropriate patient for orthobiologics? You betcha. Now, which orthobiologic would we use? Well, we know that PRP only has type 1 collagen. We know that BMAC only has type 1 collagen. Bone is type 1 collagen. SVF, is there a whole lot of collagen in fat? No. All right. All right. What about umbilical cord tissue? We know that there's type 1, some type 2, type 3, type 5, 7, 9. We also know that that umbilical cord tissue is not going to cause a pro-inflammatory response. Well, this gentleman's already got lupus. He's not healthy. His immune response is blunted because he's got long COVID, right? And we know that he can't down-regulate inflammation. So if I put PRP, BMAC, SVF in that knee, and it causes a pro-inflammatory response, what's the clinical manifestation of that pro-inflammatory response in somebody who's on steroids for lupus, has long COVID, has a grade 2 meniscal tear, and is 74 years old? The way that manifests clinically is about like this. You do the injection on Thursday, and on Sunday at about 10 a.m., you're getting a phone call from whoever's covering you that a patient that you did an injection on Thursday has a persistent diffusion. Now, you have a choice, and a pretty big one, because a persistent diffusion in a 74-year-old patient who's on steroids, who's immunocompromised, after you did PRP, BMAC, or SVF, all of which are lovely potential foci for infection. That persistent diffusion is either one, a pro-inflammatory effect, or number two, is a smoldering septic joint. And on a Sunday, no matter where you are in the country, and I practiced in Southern California and I currently practice in Nevada, I can tell you what, you better get eyes on that. Because if you're not getting eyes on that knee, and it comes Monday, Tuesday, that patient's calling you with a low-grade fever. And that low-grade fever in somebody immunocompromised with lupus on chronic steroids actually means that's a very, very sick patient. And they don't manifest a high fever because they're that sick, right? That's a patient that should be admitted to the hospital, because now it's not just a septic joint, it's probably bacteremia and maybe a little bit of potential, widespread sepsis. That is a huge problem. So in this scenario with this gentleman who's not healthy, who has a, orthobiologic cartilage-based defect and who has a full complement of cartilage-based defects, meaning type 1, type 2, and type 3, I don't think there's really any choice. Wharton's jelly is almost without question the most common sense thing to use. Just based on a 10,000 feet, above the tree's view. If you want to run into every tree, sure, put that patient to sleep. Do a BMAC on that patient, right? Destabilize the pelvis by taking 2-3 cores out. Put that BMAC in the knee, all right? Let that knee swell up pretty good for 3 or 4 days. And let's just kind of roll the dice and see if he gets more sick, because we put a foreign body in the knee and his body is going to develop a response irregardless. Now, in the asset list, you will see a study that looks at the complication rates with BMAC in particular. Care to guess what the complication rate, the accepted adverse event rate is for autologous allografts, in particular PRP and BMAC? Care to guess? 40%, meaning the acceptable adverse event rate for post-injection effusions is 4 out of 10 patients. Well, I can tell you what, I practiced in California again, and I practice in Las Vegas now. If 4 out of every 10 patients that I saw developed an effusion, I would definitely get a warning letter from the medical board. Because in this day and age in medicine, you don't need to actually harm a patient. There doesn't need to be a tort for a patient to send a response to the medical board to complain that you didn't fulfill your duty, that you violated the Medical Practice Act. All they have to do is feel like they had an unsatisfactory outcome or they didn't get better enough. And they can send a letter to the medical board, and you get the wonderful pleasure of having the medical board investigate you and destroy your life. I've been through it personally for 4 years. I can tell you, you do not want that. I wrote a book about it. It was terrible. It almost ruined my life. 40% is an inexcusably high amount of effusions if a patient is unhealthy. And so this is why this simple category of looking at whether the patient's healthy, what category of cartilage-based defect they have, and what type of cartilage-based defect is involved is really that elementary. All right. Now, let's get a little bit deeper into the science, because I know everyone asks, okay, Dr. Martin, so I get the fact that, there are cartilage-based growth factors in these human cell and tissue products. That's all lovely. What I don't understand, Dr. Martin, is how it works when I put it in a patient. What happens? Because, what I've been told is that if I just do an injection, right, and I give a patient stem cells, that inflammation is going to happen and the stem cells are just going to go where they're supposed to, and they're just going to fix the problem. That's what happens, right, Dr. Martin? I did a lecture on this. It's in the Facebook group, and I got a little animated about it because that's the most nonsensical thing I've ever heard. Okay. Okay. Let's review this. We have a lot to get through, but we're going to do this one last bit of science because it's terribly important. Okay. We're just going to dispel some myths. All right. Yeah, that's not what we're looking for. We're going to do it this way. Lateral mass, Facet complex, spinous process, lateral mass over here. All right. We have spinal canal. We have intervertebral disc. We have spinal cord here. All right. Actually, there's a lot we can do with this. All right. Nerves exit here. Nerves exit here. I give an injection paraspinal. Okay. Of whatever product. I don't care what product you use. PRP, SVF, BMAC, or Wharton's jelly. right? What is the likelihood, just common sense likelihood, that injecting a product paraspinal is going to make it to the intervertebral disc? What's the likelihood that it's going to go through the muscle, all the muscle fascia, go past the ligamentum flavum and all the posterior spinal structures, go through the dura, through the epidural space, through the CSF, right, through the anterior longitudinal ligament, and then into the avascular disc itself, make its way through the annulus fibrosus, and then find its way into the nucleus propulsus? What's the likelihood of that? About zero, right? The likelihood that I can levitate myself by saying Wingardium Leviosa, all right? So what really happens when you inject something here? Well, when you have disc disease, right, from a disc protrusion, that disc protrusion has a mass effect on the nerve that exits, number one. Number two, that disc is a foreign body. And that disc that is a foreign body causes a tremendous amount of inflammation, which does two things. Number one, it chemically burns the nerve as it leaves the spine. Number two, that chemical burning of the nerve and the mass effect from that foreign body on the nerve cause pain. And what does pain do? Causes tremendous paraspinal splinting in the three muscle groups that run from the base of the skull to the tailbone. So if I put a biologic paraspinal in a patient, sorry about that, feels better, looks better, all right? If I have put a biologic there and that patient feels better, what actually happened? Not a whole lot different than this thing hitting me in the head. I had an inflammatory response that then caused pain, and my pain caused a reaction. Now me, I want to protect my head. But what do the paraspinals do? I wish I could say that was planned, but it wasn't. The paraspinals cause a reactive spasm. And that reactive spasm, when you have bones that are stacked up on top of each other, lateral mass, lateral mass, paraspinal muscles sitting here and here. Paraspinals attach here and here, and they contract this way, which means that they pull the bones into approximation, which means they put more pressure on the intervertebral disc. That increased pressure on the intervertebral disc from paraspinal splinting causes pain. What is paraspinal splinting? It's prolonged contraction of the muscles with shortening of the sarcomeres and micro trauma over and over again, causing, number one, a cartilage-based defect in the fascia surrounding the muscle fibers themselves. Number one. Number two, right, a pretty significant amount of inflammation. So what does your biologic do when you gave it by paraspinal application? What it did very simply is it probably quelled paraspinal splinting. It did not affect any change here because it's not going to go through all those structures. What it did, very simply, is it quelled paraspinal splinting. Now, let's get into a little bit more of the histology, and then we will get into practical applications because I don't want this to go for like 4 hours.
So, Dr. Martin, just being a dumb layperson, I love this because, like you said in the beginning, a lot of the stories we heard, a lot of the history, and what we still, a lot of the majority of market thinks today is pluripotent stem cells. If I just IV this product, it's going to magically fix the problem because it can turn into anything it needs to. But what people don't realize, if they're using allogeneic products, these products are actually more powerful they're just more pointed, and you have to understand the foundational difference of when and where and why to apply them. It's more of a sniper rifle as opposed to a magic wand that you loaded inside of a shotgun and you're just shooting a shotgun effect, where this is very particular application. Then that's kind of what's gone on here then, right?
Exactly. And I love it. Let's get more into that sniper rifle. We're talking about differentiated mesenchymal stem cells. I'm asked this every day. Well, Dr. Martin, can you give me a cell count for products? I know you like Platinum's products. I know you use Platinum's products. Can you give me a cell count? You know what I say? No. You know why I say no? Because I don't care about the mesenchymal stem cells. And this is why. The mesenchymal stem cell itself has a number of things inside of it, all right? It's got cytokines, proteoglycans, growth factors, but most importantly, it has exosomes. And what happens when I take concentrated MSCs from whatever source, from autologous or allogenic, and I put it in the human body? If I put blood in the human body from autologous source, red blood cells are dead in 3 to 5 days. Is there any reason that MSCs should live longer? Again, if I take red blood cells or platelets from the blood, PRP, PRF, PRFM, and the red blood cells therein are dead in 3 to 5 days, how or why should the concentrated MSCs live any longer? And the thing is, they don't. Most studies demonstrate that mesenchymal stem cells from differentiated mesenchymal stem cells from autologous or allogenic source, those die in the human body within 3 days to 4 weeks. However, because I live in the desert, there's a phenomenon in the desert. And if an aloe plant is going to die, right before it dies, it shoots out this big plume. And when that plume flowers, it shoots pollen everywhere. And that is exactly what happens to MSCs. As they are in the process of dying, they secrete their exosomes. And I will say, the only thing that I care about in the MSC are, number one, the growth factors, and number two, the exosomes. For this reason. We already talked about the fact that autologous allografts, right, are pro-inflammatory. What that means very simply is that the exosomes from autologous mesenchymal stem cells are going to activate microRNA. The way this happens is MSC goes to exosome, exosome goes to microRNA, which leads to macrophage activity. And the articles herein are in the asset list at the end. The macrophage activity that you get with autologous biologics is activation of M1 macrophages. Those M1 macrophages do 3 things. Number one, they stimulate IL-6. They stimulate IL-1 beta. And they stimulate TNF alpha. Those are all excitatory. They all cause an inflammatory response. And left unchecked, the inflammatory response from M1 macrophages does not heal anything. It, in fact, left unchecked, causes apoptosis or cell death of chondrocytes. And if it's in a joint, synoviocytes. This is published literature. I'm not making this up. Okay? This is a problem. All right? We're putting PRP or BMAC or SVF in a joint, and the goal, obviously, is to cause a bit of inflammation for the body's own MSCs to migrate by chemotaxis to, say, the knee. Once those MSCs get to the knee, because the predominant growth factor there is, say, PRP. We've got a lot of type 1 collagen. Well, the body will go through collagenous differentiation, meaning the body's own MSCs will differentiate based on a paracrine effect, and they will turn into more type 1 collagen. This is critically important when we talk about aesthetics. We'll get to there as well. All right. But if there's no way to down-regulate that inflammation, if the patient's unhealthy, remember those three little circles. If the patient's unhealthy and they can't down-regulate inflammation, what do they get? They get a persistent diffusion and ultimately apoptosis of chondrocytes and synoviocytes, not collagenic differentiation. So what happens when we use an allogenic biologic? Well, the MSCs secrete exosomes that work on microRNA, and you get macrophage activity. But what is the macrophage activity? I'm going to hold on to this board so it doesn't bite me again. It's M2 macrophage activity. Is that distinct from M1? You betcha it is, because it's immune privileged. What does that mean? It means it does not cause inflammation. You increase IL-10. You increase ARG1. You decrease IL-1 beta. This is an anti-inflammatory response, a profound anti-inflammatory response. And in the presence of reduced inflammation, you promote collagenic differentiation. Now, for all of you who have never heard this term, collagenic differentiation, literally, this is what we are talking about when we're talking about biologics. We are talking about the body healing itself at a cellular level. I hope everybody got that, because I'm going to get rid of it, because we're going to talk for 2 minutes about collagenic differentiation. At a cellular level, if I have a situation where the patient is healthy, right? I'm sorry, it doesn't even matter if they're healthy, right? Say it's orthobiologic, right? And it's type 1, 2, and 3. All right. If I'm using an immune privileged product, it doesn't matter if they're healthy. If I'm using an immune privileged product, inflammation is not going to be a problem. So without inflammation present, if I put in the necessary growth factors for an orthobiologic cartilage-based defect, what happens? What happens is the body at a cellular level makes more type 1, more type 2, and more type 3 collagen. This is the key to all biologics. If you can modulate inflammation, either by way of the patient being healthy or using an immune privileged product in someone who's not and can't modulate inflammation, if you're able to ascertain exactly what it is from a category you're trying to ameliorate by way of supplementing cartilage-based building blocks, the body heals itself at a cellular level. And this is how and why I hate the term stem cell. Because the term stem cell used by practitioners is disingenuous in that you're saying, I'm waving my stem cell wand and it's going to treat you. No. All biologics is no different than taking care of a patient with osteoporosis. In a patient with osteoporosis, hopefully you can see this. If I give a patient calcium, magnesium, and vitamin D, ideally, I'm going to keep their bones healthy. All right. Now, anti-inflammatory diet, load-bearing exercises, having a healthy gut without leaky gut, having a functioning terminal ileum, all those things are good things. All right. But by and large, if I give somebody with osteoporosis calcium, magnesium, and vitamin D, I'm going to keep their bones healthy. What happens if I just give them vitamin D? If I just give them vitamin D, is a patient with osteoporosis going to fracture? You betcha. Because you can't eat enough calcium, magnesium, and vitamin D to keep your bones healthy. Please tell me the last time you had a lovely diet of type 1, 2, and 3 collagen. I'll wait. We'll be here for much longer than 2 hours. None of you have eaten enough type 1 collagen, type 2, or type 3 collagen to supplement the remodeling process that's happening in your skin, in your knees, and everywhere else on a daily basis. Because every day we age. If you've seen any of my prior lectures, we age 3 ways. We have photoaging. The sun ages us. Those UVBs break tissues down. Number 2, we have chronologic aging. Today, I am older than I was yesterday, and I know because it rolled out of bed this morning, right? And number 3, environmental aging. And that's the most critical. For me, I have Graves' disease, I have autoimmune arthritis, I have seronegative spondyloarthropathy, all right? My environmental aging is profound, profound. So what can I do to maintain the homeostasis in my knees, my shoulders, my back? Exercising twice a day, lecturing, traveling all over the world, giving lectures, being in 8 and 10-hour depositions, defending clients. Anti-inflammatory diet's great, right? Supplements are great, but can I supplement my way to type 1, 2, and 3 cartilage? I can't. I have to use something else. I have to supplement from outside body, typically, to get that robust collagenous differentiation and specifically comprehensive collagenous differentiation. Now, let's make this practical because I know that's why you're all here. Dr. Martin, make this practical. Make this make sense. All right. All this sounds lovely. M1, M2, FDA, DEA, make it make sense. Okay, let's get practical. All right. We're going to get into cosmetics. Okay. We're going to start there because cosmetics is about the hottest topic in biologics right now. Number one, cosmetic applications of biologics is not aggressively regulated by the FDA, so we can actually erase that off the board. You still can't tell somebody you're going to diagnose, treat, prevent, or cure disease. You're not going to turn them into Farrah Fawcett circa 1975. That's not going to happen. All right. They're not going to be Brad Pitt in A River Runs Through It. That's not going to happen. All right. So let's take, I love this topic. We're going to take the face. All right. We have a lot of estheticians on this call. We have a lot of people going into aesthetics. All right. And microneedling is hot. One of the fastest ways to build your business is to start aesthetics and to microneedle. Okay? Eyebrows, eyebrows. Now, when we microneedle, all right, we tend to microneedle at 0.5 millimeters on the forehead, 1 millimeter on the cheeks. Nobody microneedles the under eye. Maybe 2 millimeters on the jowls. And then on the chin, and some people have 2 and 3 and 4 chins, right? We microneedle at 2.5 millimeters. This, in observational studies, is nonsense. Now, I'm not trying to upset anyone, all right? People have microneedled the same way for the better part of 20 years. The reason it's nonsense is because almost everyone uses BLT prior to microneedling. They use benzocaine, lidocaine, tetracaine, or some mix of that. All right. Benzocaine, lidocaine, tetracaine can get very, very potent. You can get a 29.99. All right. Why does this not make sense? Okay. What are three little circles? What is the skin subtype cartilage we're looking to ameliorate? Type 1 collagen and type 3 collagen. All right. There's something else here too as well, which is elastin. All right. This is now cosmetic, this healthy or not healthy. Okay. Say a patient is not healthy. They have long COVID and you decide to use PRP on the face. What happens when you do a vampire facial on an unhealthy patient with long COVID? That face swells up aggressively for 3-4 days. Why do most people get microneedle facials? I think I read a study that over 70, I didn't cite it in the asset list, but over 70% of people get microneedling for a specific event. And those events are in 1 to 2 weeks from the time they get microneedled. To be perfectly honest, they're like 4 days from the time they get microneedled. So if you have somebody getting married 4 or 5 days and you give them a vampire facial, a deep vampire facial, and you used BLT, right? What's going to happen? Well, they've got long COVID. They don't have the ability to down-regulate inflammation. You're going to get unopposed pro-inflammatory response from M1 macrophages. You're going to stimulate IL-10, IL-1 beta, and TNF alpha. They are going to look like they have anasarca for their wedding. Promise you they're not going to be happy. So what do I suggest instead, based on the literature? Based on the literature, going back to 1990, lidocaine in the skin after 30 minutes penetrates 0.5 centimeter, 5 millimeters, 5.0 millimeters. Well, the deepest that we're microneedling is 2.5 millimeters. So if I put any biologic on the face and I'm microneedling it in, and my lidocaine's penetrating to a depth of 5 millimeters at 30 minutes, what exactly did I accomplish? Nothing. Because lidocaine since 1990 has been shown to be cytotoxic to mesenchymal stem cells. Not only is it immediately cytotoxic to MSCs, it actually impairs collagenous differentiation, what we want, up to 2 weeks after application. Now, I know what you're all thinking. Look, I've done PRP facials on patients and, I use BLT and they got a great response. Okay. They didn't get a great response. No offense. They got a good response. You don't know what a great response is because you haven't done a microneedling with no BLT, 0 BLT, and 0.25 millimeters. You haven't done it yet, all right? Most of the time when we're using a biologic, all we need to do is break the skin. Because if that biologic has MSCs, has exosomes, and cosmetic exosomes are the hot topic, exosomes cross the dura. They're 50 to 100 nanometers in size, typically with ALIX expression and CD expression, all right? If an exosome is 50 to 100 nanometers, it can move 2.5 millimeters in the subcutaneous tissue. If it can cross the dura, it can move a few millimeters through the subcutaneous tissue. And in observational studies that we've done with the 1,200 doctors or so, that I've talked to in the past probably 2 years as outside medical advisor for Platinum, this works wonderfully. No BLT, none. All right. Now, Dr. Martin, that's all lovely. Walk me through a facial then, if that's not what you're going to do. Okay, let's walk you through. Let's talk about the tools for a facial because I like to be granular. All right. Do I need BLT? No, I don't. Most of you are sitting in your clinic or at home and you have a skin pen. If you represent skin pen, I'm sorry to tell you, today is not your day. The tools you need are witch hazel, W-I-T-C-H. My spelling was never good. My wife will laugh. All right. W-I-T-C-H hazel. Most of you don't know that witch hazel comes alcohol and alcohol free. We want alcohol free witch hazel. We want a Dr. Pen M8. Why do we want a Dr. Pen M8? I am not paid a penny by Dr. Pen M8. They have never given me anything. Dr. Pen M8 you can buy on their website for $150. How much is a skin pen? $500 to $800. That's not the big pain, all right? It's the refill cartridges. You can buy refill cartridges for the Dr. Pen M8 between $2 and $4 a piece. How much is the refill cartridge per patient for skin pen? $82. You are destroying your net revenue using a skin pen. Please consider a Dr. Pen M8, all right? I prefer just a 36 pin tip. They make a 16, they make a nano. I use 36 for everybody. All right. How am I going to microneedle? I'm only going to microneedle at 0.25 millimeters. I'm also going to use biologics. All right. What I typically use, I use a lyophilized exosome, something called Nano EX. It is 30 billion lyophilized exosomes, and I add it to hyaluronic acid, trying to achieve a volume of 4 to 6 cc's. Now, here's where it gets important. When most patients come to your office, they've washed their face, meaning their face is dry. And I'm in Vegas, everyone's face is dry. I don't care if they have moisturizer. Your witch hazel, you're going to prep the face twice with witch hazel. All right? Once you prep the face twice with witch hazel and it's dried, you're going to reconstitute a lyophilized exosome with hyaluronic acid. That will give you a between 4 to 6 cc's. Now, most people start to apply it as a serum. They apply it all over the face, and they start microneedling forehead, right or left. We can glide with it, Dr. Pen M8, right? We don't have to stamp. However, because that face was just washed and it's dry, when you put a combination of exosomes and hyaluronic acid all over the face, by the time you get to this cheek, if you start here, go here, go here, by the time you've got to that cheek, it's dry. All of your biologic has been absorbed by the skin. So please apply regionally. Start left upper, microneedle, drive it in. Apply like a serum to the left upper. Microneedle it in, apply as a serum to the right cheek, microneedle it in, left cheek, right jowl, left jowl, chin. In this way, working systematically from left to right down the face, you don't run out of biologic, all right? Results are fantastic. Now, when I microneedle anyone, it's no different than if I'm doing an orthobiologic application or an immunologic application. I like 3 to 4 applications, 4 to 6 weeks apart. I almost always like a 0, 4, 10 weeks. At a minimum, 0, 4, 10 weeks. Okay? Why? Because the skin has to heal. even at 0.25 millimeters, we still need the skin to heal. Now, I mentioned earlier that the skin in particular is type 1 collagen, type 3 collagen, this is the dermis, and elastin. All right. I'm not here to badmouth at all biostimulants, but what I am is to address them. All right. Everyone is familiar with complex HA. Everyone is familiar with radius sculptra. All right. They are considered biostimulants. They are specifically synthetic biostimulants. Synthetic in that this is complex HA. This is even salmon sperm. This is radius. This is sculptra. All right. Synthetic meaning that the effect continues and perpetuates, meaning there is no feedback inhibition. There's no turning it off. When you use complex HA, plastic surgeons have identified complex HA in folks' faces 10 years after application. And even with hyaluronidase, they still can't get it out of the face. We've heard of filler face. If you have not, this won't be the last time you hear it. Filler face is a phenomenon coined by plastic surgeons because when you put lots of complex HA in the face, when you put something like radius, which is calcium hydroxyapatite, which is type 1 collagen, all right, it increases the tensile resistance of the skin, meaning it makes the skin firm. Great, that's lovely, right? Not if you're trying to do a deep plane facelift. Not if you're trying to pull the skin and get a clean suture line behind the ear, the tragus. No, it's terrible. Now, most of our US population is diabetic or pre-diabetic, 30 to 35%, depending on where you are in the country. If you have a diabetic or pre-diabetic with a big face full of filler, with an increase in tensile resistance of the skin, are you as a plastic surgeon seeing a bunch of filler face going to do that surgery? You are not. You're not going to do that surgery. Why? Because the increase in tensile resistance on the skin is going to put tension on your sutures, and traction on your sutures typically increases the thickness of your scar. It also leads to keloid formation. Keloid formation in the face of plastic surgery is a nightmare. No surgeon wants a keloid. No patient wants a keloid. So this is why fillers are falling out of favor profoundly. Nobody's using filler anymore. All right. They are transitioning to natural biostimulants, meaning umbilical cord derived exosomes, most prominently, sometimes Wharton's jelly. So let's talk about that. How can we use natural biologics? Why do we use natural biologics? Let's get into umbilical cord derived exosomes first. Umbilical cord derived exosomes. This is probably a $3 to $7 billion market, exosomes in the aesthetic space. Why are umbilical cord derived exosomes better than, say, plant derived exosomes? Where do plant derived exosomes come from? Please Google it. You will not be happy with the result. Plant derived exosomes come from citrus fruits. Yes, limes, lemons, oranges. That's where most plant derived exosomes come from. So if you feel like spending $150 to $400 for a vial of lime juice, go for it. I just don't think it's going to work that well because how much collagen is in citrus fruits, in particular, type 1 and type 3. How about none? All right? How about none? What do we have in umbilical cord derived exosomes? Number one, we have growth factors, right? And those growth factors have type 1 collagen and they have type 3 collagen. Wonderful. What do we also have? We have vascular endothelial growth factor and we have placental growth factor. essential growth factors for angiogenesis. For any healing, we need new blood vessel formation, all right? We also, and the article is cited, have growth differentiating factor 11. Why is growth differentiating factor 11 sexy? Because it only exists in two tissues in the body. Growth differentiating factor 11 exists in the umbilical cord, specifically the intermediate layer of the umbilical cord. It also exists in, the intermediate layer of the placenta, amnion, chorion, intermediate layer. You have elastin, very concentrated elastin in the intermediate layer of the placenta. It's also present in the umbilical cord. And growth differentiating factor 11 stimulates tropoelastin. And what does tropoelastin do? It's the precursor for elastogenesis. Our three biggies when it comes to facial aesthetics are type 1 collagen, type 3 collagen, and elastin. And with umbilical cord derived exosomes, you get all of it, right? We also know that they're immune privileged and they down-regulate inflammation. It's not a drug, it's not an anti-inflammatory, it down-regulates inflammation. So where are umbilical cord derived exosomes used most commonly? Most commonly, topical, all right? So you've got a lyophilized product. It's used topical, typically by microneedle. All right. Can you inject umbilical cord derived exosomes? You can. You want to make sure that you're using a product that does not have proteins or peptides. If you're using Platinum's products and you want to inject exosomes, you want to use it for nasolabial folds or cheeks, even under eyes. All right. What would you use? If you're going to inject, you're going to use a product called Nano Air. Nano Air is 50 billion lyophilized exosomes, but no proteins or peptides. You would reconstitute this with normal saline and inject. Typically, I like 4 cc's. 4 cc's is enough to sprinkle it around, nasolabials, cheeks. All right. Is there anything else that you could use? Well, you can use Wharton's jelly. All right. Where are we seeing Wharton's jelly be applied for aesthetics? Under eyes. Volume deficits under eyes. Can you use it nasolabial folds? You can. Can you use it temples? You can for temporal wasting. Where do we see patients that have hollowness in the under eyes, deep nasolabial folds, hollowness in the temples? Weight loss patients on GLP-1s. Why? Because they're getting sarcopenia. Recent clinical trials demonstrate that 40% of the weight loss in patients on GLP-1s is from sarcopenia, from loss of muscle mass. So when you look at a patient's under eyes, and those under eyes are purple, they're not purple because of blood vessels. They're purple because the fat under the eye is gone, and you're seeing the underlying muscle. So you need to be very, very careful with under eye applications. I'm not a big fan of microneedling for under eyes. The reason, because if I see purple, I am very close proximation to the fascia over the muscle. And so if you microneedle too deep and you create an inflammatory reaction, you can actually cause an adherence of the fascia over the muscle to the underlying subcutaneous tissue, and it will pinch and pull every time the patient blinks their eyes. It is not a great thing if you have that happen in your office. Better would be to use something like Wharton's jelly, which is going to have naturally occurring hyaluronic acid, type 1 collagen, and type 3 collagen. I always recommend a aesthetic cannula. If I'm using aesthetic cannula, I'm always using a 25 gauge cannula. Please do not use a 27 gauge cannula. This is like using a needle. It will go right through a blood vessel. And remember, Wharton's jelly is tissue-based. The product you would use from Platinum, if you were going to inject for volume loss, is nano jelly. Okay? Is there any other product that's being used in aesthetics? As a matter of fact, there is. We do not have a lot of providers doing it, but some are injecting the lips. Okay? If you are going to inject the lips, any of you injectors out there know you have to be crazy, crazy responsible because it's very easy to get a vaso-occlusion in the lips. That vaso-occlusion in the lips is no different than O shots and P shots. You have end arterioles in the lips. You have end arterioles in the clitoris and in the head of the phallus. So if you remotely decide that you want to use a biologic as a natural biostimulant, a cosmetic, allergenic biologic, you want to use, if it's Platinum's products, you want to use nano jelly. I'm sorry, nano flow. My apologies. Nano flow is aqueous. It will not cause vaso-occlusion. So if you're doing O shots, P shots, lips, and you want to use something where you have end arterioles, NanoFlow is the product you want to use. All right. Now, we've done a bit of aesthetics. All right. I'm going to move a lot faster because we just have a ton of stuff to go through, and I want to try to make this actionable for everybody. We are going to get into scalp restoration quickly because scalp restoration's hot. After we do scalp restoration, we're going to talk about knees, which applies to any large joint. We will then talk a little bit about neurologic deficits and then finish with immune. I know this sounds like a lot. I'm going to try to finish all of this in 30 minutes. So I'm going to take a sip of coffee.
Dr. Martin, just so you know, I know you like getting updates. We're holding over 96.2% of attendance. So
Fabulous.
everyone's
Okay,
engaged and everyone likes it. So
30 minutes and we'll be out of here. This is going to be our lightning round because I know it's late, especially for you folks on the East Coast. All right, let's get into it. Hair loss. All right. There are 4 determinants of hair loss. All right. 1, 2, 3, 4. The first 3 are blood flow. Okay. Cholesterol blocks end arterioles. All right. Peripheral conversion of dihydrotestosterone causes inflammation that causes vasospasm. Okay. Number 3 is peripheral conversion of dihydrotestosterone. The last one, believe it or not, is vitamin deficiency. All right. Vitamin deficiency is your last cause for hair loss. When we are talking about the scalp, we have the stratum corneum, where your A delta and your C fibers exist. These are your pain fibers. All right. We have our subcutaneous, right? Then we have much deeper. Our hair follicle sits here, down 4 millimeters. I know everyone wants to inject, and they want to inject PRP or they want to inject biologics. I've done it all, and we've investigated it all. What do you need to do to promote scalp restoration? Just microneedle. Just microneedle. All right. When you're going to do your dermal injections, what do? You put BLT on. What is BLT doing? Well, it's going down deeper than the hair follicle, 5 millimeters. So it's denaturing every bit of biologic you're putting in. Okay. If you're using PRP, what is that going to do? It's going to cause tremendous inflammation. Well, inflammation is the second and third cause of hair loss. Why do we want to cause more inflammation? All right. My advice, what works best? Let's go to tools again. Again, witch hazel. Sounds familiar, right? Dr. Penn M8. I use a 0.25 millimeter microneedle because I don't use any anesthetic. All right. Microneedle. I use a lyophilized exosome and I use hyaluronic acid. All right. This is pretty stinking good. Use about 7 cc's of HA and NanoX. What is better if you're using Platinum's products? What I use for every patient, I use Nano Jelly. I use NanoX. And I use a GHK copper peptide complex. Nano Jelly is 3 cc's. Copper peptide is 4 cc's. That gives me my 7 cc's. Same. Why am I microneedling? Very simple. Microneedling at 0.25 is not going to cause pain. So I don't even need to worry about the A delta and C fibers in the stratum corneum, right? Once I break the epithelial layer of the skin, am I worried about my exosome traveling down 2.5 millimeters or 4 millimeters? I'm not. I'm not at all. Why do I use Nano Jelly? Well, this bulb of the hair follicle is type 1 collagen and type 3 collagen. What does peripheral conversion of dihydrotestosterone do? Cause inflammation. What is unopposed inflammation with glutamate, aspartate, calcitonin, and G-related peptide do? It breaks down collagen. So if I'm using Nano Jelly that's got type 1, type 3, a little type 2, 5, 7, 9, and HA, right? I'm supplementing that cartilage-based defect. Fabulous. We already said that exosomes have potent vascular endothelial growth factor and they have placental growth factor. Well, blood loss, lack of blood flow, that's what I need, right? Some exosomes to stimulate new blood vessel formation, right? We also have growth factors. We also down-regulate inflammation. Fabulous. Why am I using GHK copper peptide? GHK copper peptide is typically used in surgical scalp restoration. It does down-regulate inflammation, but number two, it does really promote mitochondrial activity and supports new hair growth. This is what I use. No different than scalp restoration. I'm doing 4 applications 4 to 6 weeks apart. Okay? Now, this seems too simple. It seems like, wow, I mean, that seems awfully easy. What about scalp blocks? What about ring blocks? This is far easier. If you don't know how to do a scalp block or a ring block, should you go learn? I had Dan McGrath, who has one of the best hair institutes in Texas, teach me how to do a ring block. It's painful. It's really painful. I did it on my wife twice. Man, she was pissed. I mean, it's an extremely painful process. And the results, at least clinically, for many of our providers are better with microneedling more frequently than putting a bunch of biologics in once by injection. Now, does that make sense? Think about it like this. Many of you are estheticians. You've used Botox. If I put 200 units in a levator once, it's still going to wear off in 3 months. All right? Volume doesn't matter because the body is always going through those 3 types of aging: chronologic aging, photoaging, environmental aging. And if that's going to happen and our body's collagen is breaking down on a regular basis and there's nothing we can do to supplement it by way of diet, more frequent applications that are less traumatic are going to have better results. All right? This is scalp restoration. To support scalp restoration, I give everybody something called a core 4. The core 4 is essential, meaning that I put everyone on topical minoxidil. I do not like systemic. It messes with hormones. I put them on nitric oxide. Nitric oxide does what? It vasodilates. All right? And we already said blood flow is a big problem. Nitric oxide causes vasodilation, works wonderfully. Vitamin D something that we lose very commonly in most vitamin deficiencies and almost any weight loss paradigm. You're spilling things from your gut and you're losing vitamin D, right? And then finally, biotin, hair, and nails. All right, this is my core four. Because I'm going to do 4 applications 4 to 6 weeks apart, and a patient's probably going to need a repeat application at least once or twice a year, ongoing. I test every patient by making them go on a core 4 for 4 weeks before I even do my first microneedling. I know if they come back 4 weeks later and they've done none of this, they're not going to come back for more than 1 or 2 applications, which means they're going to get a suboptimal result and they're going to complain and they're going to file bad Yelp reviews or whatever else. So I don't want that. I test patients, I vet patients, select patients by seeing how compliant they are with this. If they are wonderful compliantly here, I go ahead and do my applications by microneedle. Now, word of precaution. If somebody's on topical minoxidil, they need to stop minoxidil 3 days before and 7 days after application. Why? Topical minoxidil has alcohol in it. It will denature your biologic. Are there other precautions for any biologic application? Yes, there are. We already said we're going to do precautions really quick. Hopefully everybody can see this. There's only 3, well, 4. Number 1, no lidocaine. No lidocaine, bupivacaine, benzocaine, tetracaine, any cane. It will denature your biologic. The references are in the asset list. Number 2, no NSAIDs. No NSAIDs 3 days before, 7 days after. No topical minoxidil 3 days before, 7 days after. The receipts for why you shouldn't use NSAIDs are in the asset list. There are some wonderful papers there showing that NSAIDs actually down-regulate collagenous differentiation, and they also down-regulate the expression of certain growth factors when it comes to both autologous and allogeneic biologics. Finally, my last precaution, please, cancer. Cancer is my last precaution. I don't care what you're doing. I don't care if you're doing PRP, BMAC, SBF. I don't care if you're doing allogenic biologics. Unless your practice paradigm includes the treatment of patients with cancer or having had cancer. As an interventional pain doctor for many years, with a third of my practice being cancer, at times being the only patient at the bedside when a patient passed away because it was too hard for the patient's family to watch, because they had stage 5 metastatic cancer coming out of the face or out of the breast or God knows where. I was the only one at the bedside when these folks passed, all right? There is so much emotion around cancer, so much emotion. It is not that an allogenic biologic or even an autologous biologic is necessarily going to cause cancer. I can't talk about BMAC, I can't talk about SVF or blood. Allogenic biologics, as a rule, do not cause cancer. If you take Wharton's jelly and you put it in a petri dish, generation after generation after generation, it makes collagen. If you take BMAC from a 74-year-old who just happens to have a plasma cell dyscrasia, and you put that in a petri dish, it's going to make cancer. All right. So specifically with allogenic biologics, the reason I don't use them in patients with cancer isn't because it's going to cause cancer. But if a patient who had breast cancer and who's in remission, and I say remission because I don't believe in remission, that's another story. If they're in remission for 10 years and you give them a biologic and 6 months later they see their oncologist and on a routine mammogram or CT mammogram, they find microcalcifications, who are they going to blame? They're going to blame you for sure. All right. That isn't because you caused the cancer. It almost absolutely was because of the chemotherapy or radiation therapy or other awful things we did to ameliorate the cancer the first time that then triggered oncogenes or mutation. But somebody has to be blamed. because cancer is usually fatal. And so if an oncologist or anyone else can blame you, the esthetician or the naturopath or the podiatrist or anybody else, it's definitely your fault. So no cancer. All right, let's move on. We're going to get to orthobiologic. All right. And we're going to blend orthobiologic with a little video that I did. All right. And that video I did was in the Facebook group, and it was called Going for Broke. Most of you who are watching this lecture are either in a cash-based practice or an insurance-based practice or a blend thereof. All right. Now, we are going to take a podiatrist. All right. And we're going to do an application for an ankle joint, right? Subtalar application into a joint, right? Subtalar application. All right. We're going to do an injection. Okay. We know that that subtalar cartilage is type 2. We also know that soft tissue structures in and the soft tissue structures around the ankle are type 1 and type 3. Okay. When I look at joint, this would be a large joint application. If I'm billing insurance, Medicare, that is a 20610. All right. Some people, they bill a 20611. Medicare bundles them the same. You don't get paid the additional if you use X-ray. Sometimes they don't pay for the ultrasound either. What does a standard 20610 reimburse by Medicare? About $59.95. 20611 reimburses the same. All right. Your ultrasound can, in certain MACs, reimburse a little higher. I think it's like 6256 or something like that. Okay. So best case scenario, if I did a large joint application, best case scenario, I make about $120. Worst case scenario, I make about $60. Is that really what I make? No, because you have overhead. What's overhead in a standard doctor's office? Overhead is at least 60%. So on your $120, you probably made 50. On your 60, you made 25. That doesn't include your steroid, because J codes haven't reimbursed any more than $3 or $4 for years. Depomedrol now is expensive. It's about 15 bucks. So if you get ultrasound, you're looking at a net of $35. If you don't get ultrasound, you're looking at a net of $10 to do that large joint application. That's terrible. That's unsustainable. What I talk through is something I call a hyaluronic acid model of medicine. Hyaluronic acid is not reimbursed by insurance. And so my hyaluronic acid is typically 3 applications. There are 5 applications, but HA, being unreimbursed, has a copay on average of $300 per application. Now, if you said, you know what, I'm going to use a product from Platinum Biologics called Nano Jelly, and that product costs, well, let's just call it $200. All right. $200 is cheaper than every PRP kit on the market right now today. Why? Because every PRP kit on the market today is manufactured outside the country, and with the new tariffs, all of those kits have gone up between 25 and 50% in cost. Most PRP kits are now over $350. So 200 bucks is pretty cheap. Now, if I just use an HA model, instead of charging, say, $300, say I just charge the patient for the biologic, and I charge them $400 per application. I make a clean $200 net per application, where I was making 10 or 35. If I'm a busy podiatrist, I'm seeing 60 patients a day. Maybe I do 10 injections a week. All right. Well, that's $2,000 a week. Times 4 weeks, that's $8,000 net a month just charging for the biologic. I didn't charge something crazy. I didn't charge $1,500. I didn't charge $2,000. All I did was upcharge the biologic. That's an HA model for biologics, for people that are doing insurance who want to step gradually into biologics. They don't feel like they want to overcharge a patient. Just simply upcharge the biologic. Had you charged $500, you'd have made $300 net, $3,000 a week, times 4 weeks, you'd have made $12,000. $12,000 a month is pretty substantial. That's a salary. That's a pretty good salary for the best nurse practitioner. So if you're thinking to yourself, I really want to expand, I want to open that new office location, and I need to hire a nurse practitioner, and I have no idea where I'm going to get the $8,000 or $10,000 a month to hire them, this is your path. Just simply upcharge the biologic. Standard PRP across the country is $750 to $1,500. You're not even charging that. Charging $400 or $500, making $200 to $300 net per application, and between $8,000 and $12,000 a month. There is no more elegant way of adding an orthobiologic to your practice and making cash revenue. All right. Now, let's talk about orthobiologics. All right. When we're applying orthobiologics, I have a very simple paradigm. My very simple paradigm is as such. And it doesn't matter if it's a shoulder, it's a hip, it's a knee. It just does not matter. All right. No matter what I'm doing, I look at 3 different models. Is it inflammatory? Is it degenerative? Or does it need surgery? Inflammatory. My 24-year-old comes in and he has an acute pickleball injury. He's got a pretty solid effusion. I can't tell based on the effusion whether he has an ACL tear, a meniscal tear. I have no idea. All right, but I'm pretty sure he's got something. Now, if you wanted to use a biologic, what would you use? Well, we have a significant amount of inflammation. If I put something like nano jelly in that joint, is the inflammation going to potentially denature that product? Potentially. So is there something better I can do? Yeah. I can add an exosome. I can literally reconstitute nano jelly with nano air and apply that to the joint. Now, what if I wanted to use PRP? PRP is going to cause inflammation. The patient's already got inflammation. Could I add nano air to PRP if it was a young, healthy patient? Yeah, you could do that. All right. Now, why do I think that's a better scenario than combining nano jelly and PRP? Well, the reason is very simple. In a young joint, whether it's ankle, elbow, hip, all right, we have to remember that we have a more capacious joint. So you can use more volume. But if this was a patient that had grade 3, grade 4 OA, and they were 60, 70 years old, they have substantial degeneration of that joint. They have collapse of the joint space. They have contraction of the joint volume. So if you put 4, 6, 10 cc's in this, and I know there's some prolotherapy literature out there that's using up to 9 cc's, all right? 10's probably excessive, but 9, all right? You will distend the capsule of this joint. And by distending the capsule of the joint, you will disrupt the osmotic potential and you will encourage a reactive effusion of that joint. So volume is not your friend in a degenerated joint. So I don't ever recommend any volume for any joint more than 3 cc's. Why do I use no more and no less than 3 cc's? Because the medical practice is complicated. And patients are complicated. And so the least common variable no matter whether it's a young patient or an old patient, it's a fresh joint with an injury or a very old contracted collapsed joint, 3 cc's is rarely too much for that joint. Now, still, some people have terrible joints, and even 3 cc's will cause a bit of a reactive effusion. All right? It's not common, but it still can happen. Somebody really has bone on bone, 3 cc's may cause a bit of a reactive effusion, even with an allergenic biologic. So, there are no perfect exclusions. So that's what I do for an inflammatory paradigm. For degenerative, I need to build that whole joint again. I need to rebuild the foundation of this joint. And no different than building the foundation of the house or this building that I'm standing in, what's in this building's concrete floor? Not just concrete. There's a bunch of structural steel, a bunch of cross-linked structural steel inside this concrete. Rebar. What is the rebar in the joint? It is extracellular matrix. All right. So if I'm going to apply a biologic in somebody that's got grade 3, 4 cartilage-based degeneration, I'm going to use something like NanoFlex. NanoFlex is either 150 or 300 milligrams of Wharton's jelly. It's got collagenous growth factors. Awesome. That's your concrete. But it also has matrix, extracellular matrix. And that matrix is your rebar so that you get robust and comprehensive collagenic differentiation. Now, what about a surgical joint? What about somebody with a knee, let's say, and they've got a meniscal tear plus a partial tear of the medial collateral ligament? What if they've got a rotator cuff tear plus a labral tear, a slap? All right. Here, I'm using something like NanoFlex because I want my extracellular matrix, and I add NanoFlow. Right? Why do I add NanoFlow? Because NanoFlow is about the best concrete out there. It's aqueous. It's wonderful. I had a professional athlete, very, very, very well-trained martial arts coach, and he just had a frozen shoulder. Right? Almost everyone that has a rotator cuff tear, they get shoulder surgery, and then they kind of look like Captain Morgan, right? They wear this stupid little brace that keeps their arm out like this, and they almost always get a frozen shoulder. And he did. And then he got manipulation under anesthesia, meaning they broke up all of his scar tissue. Now, he had two things. He definitely had a bunch of inflammation because they just broke up all this scar tissue. And what does his body want to do? His body wants to go right back and re-scar that tissue. So what would I use in that scenario? Well, I don't need matrix. He's already had surgical repair. And if I put in a bunch of matrix, I put in a bunch of ECM like NanoFlex, I'm just going to get potentially a lot more collagenic differentiation. What I want is balanced collagenic differentiation without a bunch of extracellular matrix. So what did I use? I used NanoFlow for that gentleman, but I also added an exosome because he had a pretty solid effusion. And I combined NanoFlow with NanoAir, and he did wonderfully. Can't tell you who he is, but he's out there fighting and training and using pads, and he's amazing. But his shoulder was bad when I saw it. We did one application. He did wonderfully, absolutely wonderfully. Okay, that is orthobiologic. Now, let's get into neurologic, all right? Neurologic comes at us in two different paradigms, central and peripheral. We're going to tackle peripheral first because central segues into immunologic. Every nerve has three distinct layers. We have the endoneurium, we have the perineurium, and we have the epineurium. When we look at an axon, okay, and we have damage of the nerve, Damage in the outer third is called a neuropraxic deficit. By definition, neuropraxia is damage to the outer third of the nerve. What's the outer third of the nerve? The outer third of the nerve is type 1 and type 3 collagen. It's dense irregular tissue. So can you apply a biologic for that cartilage-based defect? You betcha. You can apply it focally. For neuropraxic deficits in peripheral nerves, can we apply a biologic for neuropathy? Well, neuropathy is a disease. So can we use a biologic to treat neuropathy? No, we cannot. Can we apply a cartilage-based building block supplement to supplement a cartilage-based defect in the outer third of the nerve? You betcha. How does that work, and why does it work? We know that Schwann cells attach to the outer part of the nerve. And we know that information travels down the nerve by saltatory conduction. All right? That saltatory conduction, which allows impulses to travel quickly down the nerve, like jumping every 15 cars driving from Vegas to Southern California, only happens because Schwann cells attach to scaffold. Again, Schwann cells, which are responsible for creating the myelin, the insulation around nerves, around A delta and B fiber nerves, not C fiber nerves. C fiber nerves are unmyelinated. But that Schwann cell only attaches to scaffold. And because it only attaches to scaffold, if you don't have collagen, you don't get collagenic differentiation of the outer third of the nerve, and you don't get propagation of myelin down the nerve. So if you can restore the scaffold, you can restore the Schwann cells and ultimately saltatory conduction of nerve impulses down the nerve. That's pretty sexy, right? So if we're looking at somebody, and say we're looking at somebody with a neuropraxic deficit of the foot, all right? So let's draw foot. Let's see, foot. All right, and say this is big toe, little toes out, leg goes up, calf. All right, here's their knee, cap, and up. Hamstring. All right, this is a terrible leg. Sorry, I know it's late, but that leg is awful and nobody's foot looks like that. So medial malleolus, which is terribly important. Calf, that's better. That's better. Okay, and they got a little Osgood-Schlatter as well. Okay, so two nerves supply the foot. All right, this is the lateral portion of the foot. I wish I'd drawn the medial, but I didn't. Actually, well, we did that way. If this was the left foot, this could be left foot, big toe would be, that's fine. Left, this is medial. Okay, say this is our left leg. All right, we're looking at the inside of the left leg. This is the medial malleolus. Wonderful. All right. We all know that the sciatic nerve is not just one nerve. The sciatic nerve is bundled common peroneal and tibial nerve, wherein the common peroneal comes outside the leg, down the front of the leg, and subserves the top of the foot and the first web space. The tibial nerve comes down the back of the leg, wraps around the medial malleolus, goes through the tarsal tunnel, and goes to the bottom of the foot, innervating the calcaneal nerve, the medial plantar nerve, and the lateral plantar nerve, right? Big toe all the way to little toe. So, practically speaking, could I apply a biologic in someone with a peripheral neuropraxic deficit? I could. I could apply Wharton's jelly, subcutaneous here, just proximal to the tarsal tunnel, before it branches into calcaneal, medial, and lateral plantar nerve. On the opposite side of the leg, if I'm looking at the lateral portion of the leg, right? And your fibula is here. Common perineal wraps just under the fibula, right? In somebody with foot drop, you can actually tap, just caudal the fibular head, and you can get a tenelle into the bottom of the foot. You can apply just there, all right? Before the common perineal splits into the superficial perineal and the deep perineal. And in observational studies, have we seen improvement in patients with neuropraxic deficits? Yes. There's a large group out of Branson, Missouri. It's actually an integrated chiro group. They are trying to collect 250 patients. They've been applying this paradigm with 3 applications, 0, 6, 12 weeks. What have they seen? Within 6 months, they've seen up to 42% improvement in monofilament testing, which is objective. A little monofilament you press to the bottom of the foot, based on the amount of resistance, the monofilament breaks, all right? 43% improvement in nerve conduction velocity by electromyogram, EMG. That is very significant. Both of those are objective tests. At least in this group, we've now collected, I believe, over 150 patients. Over 70% of their patients have shown over 40% improvement in monofilament testing and in electromyographic studies at 6 months after 3 applications. That is very impressive. Compared to just burying somebody with Lyrica or gabapentin, or giving, a 70-year-old a tricyclic antidepressant and having them go nuts, this is pretty sexy, all right? Now, we said that we were going to transition by talking about central application for neurologic issues, all right? This is very experimental. Is there literature on systemic administration of biologics? Yes. It is far more robust looking at systemic administration of exosomes than it is systemic administration of mesenchymal stem cells. As I stated earlier, I could care less about stem cells. So if you were to talk to me on the phone and you said that, oh, a rep said, they have 1 trillion anything, I'm going to roll my eyes and say, that's not for you. Because if you think about it, if I offered you a little pill with 1 trillion milligrams of vitamin C, would there be any reason to take that? No. You can't metabolize 1 trillion milligrams of vitamin C. So how would 1 trillion exosomes even be counted? They wouldn't. It's usually just extracellular debris, meaning that they use a scanning electron micrograph and they just count everything on the screen. That doesn't mean it's an exosome, right? In order to be an exosome, has to be 50 to 100 nanometers. Has to have ALIX expression and it has to have CD expression. If it doesn't have all 3, it's not an exosome. The exosomes that they use at Platinum, I like. The reason I like is because there's a peer review published PubMed indexed paper for that product. It was written by Dr. Ashim Gupta, who's a personal friend, all right? There is a fabulous paper on that exosome product. That's why I use it, because I like receipts. No different than the list of receipts that you all will have after this lecture. I like receipts. And that's why that exosome product is called Nano XSOMES. And it comes in 180 billion cryopreserved. It also comes in a 90 billion lyo. Fabulous products. Okay. We were going to talk about systemic administration. Again, very experimental, right? And we're going to talk about neurologic, right? Most of us are seeing patients with long COVID. Most of us are seeing patients with dementia, Parkinson's. We're seeing patients with POTS syndrome, with all sorts of paradigms, right? When we're talking about these disease processes, can we say we're going to diagnose, treat, cure, or prevent disease? We cannot. And so we would never say that we're using any human cell and tissue product. I don't care if it's sourced from PRP or BMAC or anything else, or an allergenic source, to treat Parkinson's, treat ALS, treat long COVID, all right? You need a drug for that. We're not using drugs. We're not talking about drugs. We're talking about human cell and tissue products. And specifically, exosomes are actually a secretion, all right? Exosomes, though, down-regulate inflammation, and they down-regulate inflammation in a very potent manner. I liken exosomes to corticosteroids. They're different, though. Exosomes down-regulate inflammation by M2 macrophage pathways. We talked about that before. They up-regulate IL-10, up-regulate ARG1, down-regulate IL-1 beta. But they're anabolic. And that is the key difference that separates an exosome product that's umbilical cord sourced from cortisone or even autologous source. They are anabolic. They are not catabolic. They do not break your tissues down, right? Anyone who's seen the journal article in Radiology 2020 knows that serial application of steroids for things like osteoarthritis of the knee actually accelerates degeneration of the joints. And this is why we've seen kind of steroids fall out of favor. Well, what happens when we give somebody with lupus or somebody with rheumatoid arthritis systemic steroids for long periods of time? They're catabolic. They break the tissues down. You develop neuropathy. You develop retinopathy. You develop nephropathy. Your kidneys fail. Your eyes fail. Your nerves fail. Why? Because prolonged systemic hyperglycosylation causes inflammation, and it breaks tissues down. Umbilical cord-derived exosomes don't do that. They don't break tissues down. This is why, from an experimental standpoint, they become very interesting. Now, everything that we're talking about is immune support. Specifically, immune support, all right? If you had to use an ICD-10 code, you would want to use a code for generalized malaise. I believe it's R53.8. Don't quote me on that, but I'm pretty sure that's what it is. Generalized malaise means that a patient doesn't feel good and there's no underlying discernible diagnosis. Fabulous, all right? We didn't give the patient a disease. We didn't diagnose, treat, prevent, or cure, right? Generalized malaise just means they feel terrible. Well, let's think about this. Why do we use NAD? Why do we use glutathione? Why do we use Myers cocktail? We use it for immune support, right? Can we treat long COVID with Myers cocktail? We cannot. Can we treat long COVID with NAD or glutathione? No, you can't say that, all right? All you can say is that you're providing immune support. So if you're going to use an umbilical cord-derived exosome for an experimental purpose, and the patient has some immunologic disease, it should be done for immune support. You should not make claims and tell the patient you're going to heal them, cure them, right? And if you have to use an ICD-10 code, I would use R53.8, generalized malaise, all right? Administration, okay? Now, we're talking about neurologic administration, all right? My favorite neurologic administration is actually nebulized up through the nose, all right? Why up through the nose, all right? Well, about up here, really, all right? Cribriform plate up through the nose. We've got superior, middle, inferior lamina, all right? You've got olfactory bulb, olfactory mucosa. You've got sphenopalatine ganglion back in here, all right? It's very, very difficult to get a sphenocath in through the nose, perfectly positioned in the middle turbinate, and you have to crank up on the nose to do this and get it aligned right with the sphenopalatine ganglion. You have to put the patient in reverse Trendelenburg, meaning with their head back down, right? And you have to drop a biologic on the sphenopalatine ganglion at a rate of 1 drop per 2 minutes for it to dissolve. If you use it any quicker than that, what happens? Patient just swallowed your biologic because it dribbled back down the nasopharynx into the oropharynx and they swallowed it. Not an optimal outcome. What do I prefer? Nebulized. Nebulized all day long, right? Can you nebulize nano air? Sure, it's lyophilized. Mix it in 3 cc's of normal saline. Use a handheld nebulizer. Take off the adult mask. Put on a pediatric mask and just cover the nose. Have them inhale through the nose, exhale through the mouth. 50 billion exosomes right up on the cribriform plate. Fabulous route of administration. What's better than that? Take that 3 cc's of saline and add it to an IV bag. When you're doing an IV, it is critically important. Myers cocktail comes pre-made. It's not expensive. So if you spike the bag and you bleed all the air out of the line and you dribble Myers cocktail in the sink, you've lost like 20 cents, right? If you're using nano air or you're using nanosomes or nanoflow, if you want to use those biologics by IV route of administration, these are $1,000 a piece. Nano air is not, but it's still expensive. Please do not put the biologic in the bag first. Please spike the bag, bleed the line, site the IV in the patient's arm, start it running the IV where it's dripping slowly, and then put the biologic in the bag. Why do I say to put the biologic in the bag? All right. The only adverse events that I have seen using biologics have almost all been in IV push, and a patient developed a Herxheimer response. They got a shaky, they got myalgias. Why? Well, some of these patients are really sick, right? If you've got long COVID and chronic Epstein-Barr and chronic Lyme and you've got lupus, right, and you've got some mold toxicity, you are really sick. If I whomp you in 3 minutes with 180 billion exosomes, you're going to get a response, and not a great one, right? You may get the shakies. You may feel very agitated. You may not feel great, all right? That's not the best thing to do, all right? So I put it in a bag. What do I use? I use a 250 cc bag of normal saline. Why? Because it's cheaper than a liter, it's cheaper than 500 cc's, and it's my Goldilocks bag. From a price point, it's just right. And if I put a 23 gauge cannula in an antecubital, it's in the body in about 15 to 20 minutes. Perfect. All
Dr.
right.
Martin, will you also address sometimes flooding a patient, the temperature of the water, giving too
Yeah.
much water as well?
So precautions with IVs, very, very important. All right. If you're using a liter of fluid, that liter of fluid is sitting in your office, and your office is probably 68 degrees. And that liter of fluid is running. It's going to take an hour for that liter of fluid to run in. But what's going to happen? You're going to give that patient iatrogenic hypothermia because the fluid going in their body is 68 degrees. They're going to get the chills. And you're going to think that it's from the biologic. It's not. You just gave them iatrogenic hypothermia. That's number one. Number two, remember this. This right here is where we want to be. What is this right here? Health. The health of a patient. All right. If your patient is unhealthy, if they have congestive heart failure, if they have renal failure, please consider nebulized route of administration. Please do not give somebody who is very sensitive to fluid fluctuations a bunch of saline. All right. You're going to give them fluid overload. And if they have reduced glomerular filtration rate, if they've got, decompensated heart failure, you're going to make them worse. all right? And this is not for me to be on a soapbox, all right? But if this patient is not healthy, your first thought should not be a biologic. Your first thought should be, I need to be a doctor, all right? We had a case scenario, patient's very old, right? Diabetic or borderline diabetic, right? Headache, right? Post-viral, immunocompromised with a headache and neck pain should not immediately say to you, oh, they need 3 applications of nano air. No, it should mean what is giving this frail patient in their 80s neck pain and an occipital-based headache. Maybe let's make sure that patient doesn't have meningitis or something really bad. Please treat your patients first. Make sure they're healthy. All right. Make sure you've exhausted other therapies before you use biologics. All right. If your patient has congestive heart failure, all right, make sure that you've talked to the cardiologist. Make sure they're not on an experimental regimen, right? Before you start the biologic, please don't stop their aspirin and Plavix. All right. I don't touch any drug I have not prescribed myself. If a patient walks in my office, unless it's NSAIDs and topical minoxidil, I don't touch it. Because guess how many patients have to be on prescription NSAIDs? None. Nobody has to be on a prescription NSAID. Nobody. I think there's one case, like relapsing polychondritis. Maybe that, all right? But there's so few cases of relapsing polychondritis in the United States. I mean, okay, in that case, I don't know. I'd have to have a conversation with the patient and say, I don't know if this is going to work all that well because you have to stay on your NSAID. All right. But all of these are elective administrations. All of these are elective administrations, right? So if we're talking about immune support and that patient has a post-COVID syndrome and they're frail, please make sure that patient's stable first. If you want to do, an experimental application of, say, nano air for somebody with COPD, right? And they have profound air hunger. For the love of God, right? Get a pulmonary function test, see if they need oxygen. Don't decide the first thing I'm going to do is give them, a couple of nebulizers with a biologic. No. Let's make sure that they don't have profound air hunger. And let's make sure if they need supplemental oxygen, we get them that first. All right. At the end of the day, our job is to be a doctor first. And can biologics help? Yes. But by and large, we're looking at replacing missing, damaged, deranged cartilage. That's what we're looking at. Systemic administration of biologics is still very experimental. All right. There are some decent papers out there. You can simply Google, exosomes and whatever, nebulized exosomes and whatever, right? And you'll get 3, 4, 5 articles. All right. I didn't reference all of them because I think it's best that you look them up yourself because you'll know what you're looking for. All right. I know it's been a little over 30 minutes and I want to close saying this. For all of you that are on this call, if you're not in the Facebook group, please jump in, not because of me, but because it's a place for collaboration. I'm never going to be the smartest guy in the room. I'm not the smartest one on this call by far, right? I'm probably in the bottom 4th for intelligence. I've talked to 1,200, 1,300 doctors in the past 2, 3 years. Some of you are overwhelmingly brilliant, all right? I've just seen a lot of sick patients and I do a lot of lecturing, all right? But in that Facebook group, you have a community of people that are desperate for knowledge. If you are getting great outcomes, doing anything in your practice, please shoot a video and tell people about it. I don't care if it's peptides. I don't care if it's autologous. I don't care if it's allogenic. We as doctors practice in a very simple way. See one, do one, teach one. All right? And the more of you that show up in that group and teach others what you're doing, all you're really doing is creating a model for better and more transparent observational research. I observed this. I saw a patient with this. I observed this, right? Wonderful. Because you know what's going to happen? I'm going to think about that the next time I see a patient or the next time I talk to a doctor when I do 40 hours of consulting a week. And I'm going to bring that up and say, hey, you know what, this doctor, he was doing this and hasn't been vetted, but, have you ever seen this done? Actually, I have. I kind of wanted to, know if anyone else in the country had ever seen that or done it. Please use the Facebook group as a resource. Use me as a resource, all right? You can jump on my virtual schedule. Again, I do consulting 40 hours a week, all right? I still practice. I still love to see patients. But more than seeing patients, what I enjoy thoroughly is watching providers build a sustainable practice that serves their community and serves their family. There are so many doctors right now that can't afford to keep their practice open. There are so many that can't afford to keep a surgery center running. Orthobiologics, cosmetic biologics, neurologic biologics, immunologic biologics, all right? In the application thereof, experimental, cosmetic, or for research basis. This is potentially a lifeline where you can continue to get great outcomes for your patients, where you can continue to thrive as a provider for your community. When I graduated from medical school, my father gave me a card. My father's 83 years old. He's a semi-retired head and neck cancer surgeon. He's not an ENT. He's a head and neck cancer surgeon. There's a difference. And on that card, and I still have that card, that was 2000. It said, if you listen to a patient, they will tell you what's wrong with them. I've talked for probably 2 hours, over 2 hours. In all of this, you've probably learned at least one or two things, all right? But at the end of the day, please listen to your patients. Your patients will tell you what's wrong with them. They'll tell you the goals they want to achieve. Yes, it's great to see a patient and close a deal to do a series of injections. That's lovely, all right? But it's not more lovely than that patient getting a great outcome and telling mother, brother, sister, cousin, uncle, person in front of them at Starbucks, person next to them at the DMV. Because ultimately, the lifeblood of every practice isn't closing a series of biologics. It's new patients. And how do you get new patients? You get superlative outcomes. Right? This is why I practice the way I do. This is why I use the biologics that I do. This is one of the reasons I use platinum, right? This is one of the reasons that I don't use steroids. I don't use a lot of PRP or BMAC. I get dramatically better outcomes using allogenic biologics. Do I still use autologous at times? Yeah, rarely. The patient's super, super healthy, right? But at the end of the day, I work very hard to remember what my dad told me, to listen to patients. Because ultimately, it's the reason we all went into medicine in the first place. We wanted to make a difference. We wanted to improve the quality of patients' lives. And we wanted to make a difference for our communities. So I charge all of you, first, if you've stuck in here this long, thank you so very much for your time and your attention. Second, all of you have an extremely blessed week. I'll be praying for all of you. And finally, very few people get the ability to do what they genuinely enjoy. And I genuinely enjoy talking to providers. I genuinely enjoy listening to how you're building your practice, your dreams, your aspirations. And it is the greatest pleasure in my life consulting. in helping you all build your practices and see you thrive and see your patients and your families thrive. And so for that and for you, I'm very grateful.